out of your day today to participate in this town hall. It's going to be the first of a monthly town hall series that I really intend to keep on going. I want to have an ongoing conversation with all of you directly on, where we're updating the Medicaid program, things that we're working on to get your feedback, and then just keep an open line of communication of where you're seeing things really work and where you're seeing that things could work a bit better. So here over at Iowa Medicaid and DHS more broadly, we have a great team that is incredibly committed to doing all that they can to provide the best Medicaid services that we possibly can. That said, we know we have work to do. We always will. This is a never-ending and evolving process of program improvement. So I think you will talk to Medicaid staff and Medicaid providers across the country, and here there is no Medicaid program that exists today that is without challenges, and we all know that. So whether it's some state or federal limitations or funding limitations, all of these things are very real, and they're things that we need to talk about, but they're not always things that are insurmountable. So as a group, like I said, I really feel like it's important that we create a space where we're putting all of the ideas on the table, and we look at what can we do immediately, what can we do today to make things better, what can we plan for in the future. Some projects are going to be more long-term and require a little bit more work and resource allocation. And then what are some things that we can't do today because of some of those limitations, but we might be able to kind of do some planning so that if those limitations do drop off, we can proceed with implementation and updates. So having town halls with providers directly and our Medicaid enrollees directly is definitely a new thing. And it's one that I myself am very excited about, and the Medicaid team is really excited about. We value your perspectives so much, and we really, really do think that we'll have a better program if we have all of your perspectives woven in more regularly into our planning and development. So I know historically, some of you may have felt like you didn't have space to share your ideas and frustrations and about the program in the past. And I want you to know I'm here to listen now. So let's start fresh. And I'm here to hear whatever you have to say. I'm here to listen, and I'm here to do what I can to help. In between our monthly meetings, if you do have ideas or things that you would like to be addressed in future monthly town halls, we are working on setting up a process where you can provide that feedback. It'll likely be in an email, but we currently have several different email platforms set up today. We have one related to COVID, but we want to make one specific to this particular process as well. So I do want to thank whomever put in the chat that it is helpful if everyone puts themselves on mute when they're not speaking so that we can eliminate some of that background noise. When we do open the floor to some public comment, we'll see how it goes with people speaking, and if we can find a flow of people being able to speak where they find space. But sometimes it's also helpful to use the raise your hand function as well, or put thoughts questions, things like that in the chat. Each month at our town halls, I also want to introduce some of the staff that we have at Medicaid that are working behind the scenes really hard to do everything that they can. And so today we're going to introduce some of our leadership staff here at Medicaid. Julie, would you like to introduce yourself?
Sure. Good afternoon, everyone. I'm Julie Lovelady, and I'm the Deputy Medicaid Director. It's good to see all the names and faces of people on today. So we appreciate it, and we're looking forward to hearing from you.
Thanks, Julie. Jennifer?
Sure. Thanks, Liz. I'm Jennifer Steenblock, and I am our Federal Compliance Officer with Iowa Medicaid, and happy to have this dialogue with you all today.
Thanks, Jennifer. Paula, are you on? Okay. How about Mary? Okay, just a reminder, please mute yourself if you're not talking. Okay, if Paula or Mary come on, we'll introduce them later. Amela, I see you.
Hi, good afternoon, everyone. I apologize. I had some technical difficulties here, so joined just a little late. I'm Amela Alibasic, and I'm also part of the IME leadership team. And my role is I'm a bureau chief for Medicaid eligibility policy. So we do everything related to member Medicaid eligibility. I am so excited for this call today. So yeah.
Great. Thanks, Amela. It sounds like Paula is on. So Paula, if you can unmute yourself, go ahead. All right, we must be having technical difficulties with Paula today. All right, so I did want to give a couple of updates on some things that are in the works. We have been working to implement the legislative rate changes from this most recent legislative session. We were lucky to get some increases so that we could increase our provider rates for our home and community-based service providers, our habilitation providers, PMIC providers, nursing facility providers, some air ambulance rates. So we're in the process of working on getting those updates all in the system. They should be processing and will be retroactive to July 1st of 2021. Really thank our legislative partners for allowing us to increase those rates in those areas. We are also working on some planning related to some additional funding that we received from the federal government. Through the American Rescue Plan, we got a pretty good amount of money that we are able to invest in the home and community-based service program. Very exciting. We are incredibly thrilled of the community to invest in some upfront costs to help create better training platforms, to pilot some programs, to do some systems evaluation, and to really support our workforce in that home and community-based service setting. So I will drop the link in the chat function for anyone who hasn't been able to see that yet. Other than that, you know, there are a number of other things that we are working on, either from as a result of some bills that were passed the last legislative cycle, or just as a natural function of our operations that we work through. One thing that we are working on doing is, over the course of the next year, there are areas within our state Medicaid provider community where rates haven't been evaluated recently. And we do want to get in a more regular cycle of looking at where our Medicaid rates compare to Medicare, where they compare to the commercial market, and where they compare to our regional Medicaid partners here in the Midwest. So we are going to be doing that for a number of different areas, including mental health providers, substance use providers, physicians, dental providers, and just to name a few. But we will be working on that so that we'll have information available to help guide decisions moving forward from an appropriation perspective. Let's see. Then just in terms of communication, we will be working in ways that we can communicate better with all of you and our Medicaid enrollees. We want to make sure that we're getting everyone information timely, and like I said earlier, creating a feedback loop where all of you can provide more regular feedback. So in addition to the town hall process, as we do implement new programs, or as we're looking at rates, we want to pull in different stakeholders from some of our provider communities to help us think through all of the implications and be able to the data that we're seeing on our side. So more to come on that. We will be sure to share those opportunities with all of you moving forward as they become available, and then also, of course, working through associations to get information out to all of you as well. Okay, so I did want to leave a large chunk of this meeting to really hear from all of you. How is the program going? Where do you see ideas and opportunities for improvement? And I will go ahead and open it up. Who would like to talk?
This is Shelley Chandler. How are you?
Shelley?
I've been getting a lot of questions on 3.55% rate increases because there are rates that are not posted on the DHS website. Providers are coming to the association asking if there is a rate increase. I have assured them, yes, it's all services within HCS. However, they are not finding it anywhere and are wondering if they will be able to bill. You did say it was retroactive. I know it's quite a process with all of the services within HCBS, but if you could provide a little bit of guidance for how to communicate back to providers about how they can properly bill. Thanks so much.
Yeah, so there are likely a number of provider rates that aren't posted on the website because they are individual based, right? So we have had conversations with the managed care organizations on the need to apply that 3.55% to their current contracted rate. So from what I understand, that is all in the works. If you are having an issue getting a response or some type of answer from a managed care organization or both, Shelley, I'm always happy to facilitate a meeting. Maybe it would be helpful for you and me and the MCOs and the rest of our Medicaid team to sit down and kind of talk through the best way to get that information out to providers.
Thank you.
Okay. We can do more questions, or I can go through the chat. So it looks like we have a comment related to reimbursement, and that the current reimbursement rate does not cover the cost for long-acting contraception. So I think that that's a terrific point. We will take that back and look at it. Obviously, you know, family planning services are super critical. They are, for some women, prevention activity within the healthcare world. We want to make sure that individuals have access to it and that providers are getting reimbursed. So I will go back and talk with my team about what type of analysis we might have at our fingertips. And if we don't have anything ready immediately, we will bring that back to the next meeting. All right, so why are MCOs allowed to down code our charges? AmeriGroup has been doing this and then reprocessing once we protest. A lot of unnecessary and additional costs for both parties. I'll probably need a bit more information on what the issue is there. So I will put my email in the chat box, and if you don't mind sending me details where it is specific to your agency and your claims so that I can have the team follow up, that would be great. Okay. Okay, will FQHC clinics get a raise in reimbursement as well? Maybe that's a good topic that we can cover in a future meeting. I think, you know, really the intention is to be looking at all types of providers, and it's not necessarily that we can immediately give a reimbursement increase, but what we want to do is make sure that we constantly have eyes on it as far as where Iowa compares to markets within the state of Iowa as well as the surrounding region. And then, you know, if there is a desire from the entities that do appropriate to the Medicaid program, we would have that information available to have those conversations. So let's see, we're having a lot of issues with AmeriGroup and little support. Again, let me know about your specifics and we'll make sure to get to that individual. Okay, we'd like to have the state of Iowa put some pressure on those updating retroactive rates by the 60-day deadline. Who do we reach out to when there's significant delays in getting old claims reprocessed and paid at the higher rate? Julie, do you have any thoughts on that? Should they send a note in through provider services and we can follow up?
Yeah, I think sending a note through provider services would be perfect for this.
Great. What grants are out there for health home programs to assist members that we serve in the program? A general grant that we can use to deal with issues that have come up during this pandemic. Well, that's a great question. There are a number of resources that are available that are pandemic related. Some of them are available through FEMA. Some of them are available through other channels. Let me see what I can do to disseminate some of that information or point you to a website that might have that information. Okay, we understand that there's another MCO added to the mix starting sometime next year. Please address this, as this is a huge potential additional burden to providers and patients. I'm glad you brought this up, Dee. So AmeriGroup's contract, just from which we have limits to how long we can contracts with entities, and their contracts due to expire in 2020, actually the end of June 2023. So we are going out to bid because we have to. We have to do an additional RFP, and AmeriGroup would, I hope, submit a proposal, and then it would then be open to other MCOs as well. I don't know that we necessarily are committing to bringing in 2 MCOs. So I think that we're reserving the right to look and see, like, what's the quality of the proposals that we get back from that RFP process. We want a minimum of 2 MCOs, and we really don't want any more than 4, because we start seeing that cause some additional administrative burden, and just the number of Medicaid enrollees that we have in Iowa right now just really isn't enough to sustain probably more than 4 managed care organizations. But just over time, you know, I think that we've hit a pretty stable point with 2 MCOs. And so, you know, I don't know that necessarily there will be a 3rd. We'll kind of see what kind of RFPs we get back, but that won't happen until July 1st of 2023. And we're going to be doing a pretty long runway once the RFP winner or winners is announced, to make sure that everyone has plenty of time to test and to do all of the necessary ramp up activities so that there is minimal disruption to providers and patients. I do understand, I do hear you, that is a concern for me as well. Has there been any more information given regarding the behavior PTP edit regarding, regarding school-based Medicaid? Also, will there be a focus on school-based Medicaid provider manual in regards to CLEAR's requirements and billable services? Sheena, I think if you want to send me some additional information on what you're thinking, we certainly want to provide necessary information in our provider manuals to help support providers implement important services. We know that school-based services are critical to the program. And so we want to make sure that, to the extent that we have those school-based services in the state, and even expanding to some extent in the state, that all of those requirements are quite clear. MCOs not having the same prior authorization requirements for each service is a headache and very time-consuming to staff. Would save so much time and money if they were all requiring Ps for the same services. Definitely see your point there. I think you probably have hit on something for a lot of individuals on the call. We did work to put forward a universal prior authorization form but understand that their requirements can differ across the MCOs and honestly fee-for-service as well. I will say that one of the things I really do want to focus on and have talked to the rest of the Medicaid team about and the managed care organizations as well is, you know, when we're thinking about modernizing the way that we do things to the extent that we can, I always want to focus on reducing some of that administrative burden and reducing processes or eliminating processes that really aren't effective. So if a prior authorization is getting approved 99% of the time, is it worth having that prior authorization step in place anymore? So those are some things that we do absolutely want to work on. It's not going to change tomorrow, but it is something that is on our list as a top priority. Looks like we have another comment related to downcoding of E&M codes. So I will look into that, Monique. All right, provider services, IME provider services. So this is from Jillian and related to the billing question. We were talking about, Jillian, if you're not getting your claims paid timely, we have those kind of escalated provider issues are IME provider services, right, Julie?
Correct. We would encourage you to work with the MCOs initially, but if you're not getting a response, then we would want you to escalate that to the IME provider services website.
Okay. Does IME, AmeriGroup, and Iowa Total Care still have the COVID waiver in place for authorizations of swing bed or skilled admissions? I'm going to have to look into that, to be honest. We still do have a lot of the pandemic related waivers in place, but this one specifically, I do need to look into. We'll make sure to get something back out publicly. I know that some of the hospitals are doing some moving around of individuals because we do have a bed constraint. So I will take a look at that and see what we can do if that's becoming an issue. All right, what can be done to help expedite the handling of MCO's processing and fixing billing that has been put into a project? We are looking at some bills that haven't been paid in a project for months on end. Erica Sherman, this one is from you. I think that's another one that you could send in to IME provider services so that we could route through our escalated process. Julie, keep me honest here.
You're right, Liz, right? That's exactly right. We want to know about those so that we can work to get those resolved.
All right, Walnut Creek Psychiatry. Currently, we are treating patients from all over the state of Iowa. Thank you. I just want to say that. Please clarify psychiatric telehealth requirements post-PHE. Will it go back to original guidelines or will current practice continue? A great question. We do have a lot of things that have been expanded from just an eligibility perspective, but also a service and program perspective, program, and all of those things we had to submit through different mechanisms for approval from CMS. So the perspective of payment parity, you know, that'll definitely continue post PHE for mental health services. as requiring some, or as far as allowing for like audio only, that's something that we're still looking at. And we plan to provide notice as much as possible to providers, but there are certain service areas where access is not great in all areas of the state, and psychiatry certainly is one of those. So, ultimately our goal is to promote access statewide, regardless of where you live. And so that'll definitely be a consideration as we're looking at any telehealth policy changes post-PHE. All right, we're seeing more issues with J codes being paid. One example is J0702. What is the MCO supposed to go by? The IME rebatable list, or the data Medicaid.gov, or the FDA.gov? Julie, I'm not gonna put you on the spot, but I think we probably need to take this one back. I'm not honestly familiar about which physician administered drug this is.
Agreed. We need to research that, but we can certainly get back to everyone.
I'm just writing it down real quick. Okay. Does anybody want to ask a question, or you want me to keep reading? All right, I'll keep reading. Can you please confirm that the MCOs only cover CPT, HCPCS listed on the Medicaid fee schedule? We are having issues where both Amerigroup and Iowa Total Care reps are telling patients and our staff via phone, procedures, drugs, DME are covered, but they're not on the Medicaid fee schedule. This one is from Sue. We will look into that. I don't know the answer.
I was going to say, Liz, it might be helpful if we have some examples,
Yeah,
so that we can research those.
Sue, if you don't mind. Oh, go ahead, Sue.
Yep, I can certainly send you a few. Where should I send them?
Send them to, again, I think, Liz, you want them to go through IME Provider Services so we can kind of capture them all together?
Yeah, that sounds good. Sean, are you okay with that?
Yes, please. I'll actually put my email address in the text there so that everybody can send them my way directly.
All right. Are MCOs saving the state money? Why do we need to use them? State Medicaid worked well. Well, Mary, I think that our Medicaid staff will take that as a compliment. We do have some benefits with MCOs, and I don't know that we have always articulated that well and in one location. So I think that that's probably a good topic for us to bring up on a future meeting. As far as the MCOs saving the state money, I think that we have looked at the typical trend lines that we would see across the healthcare markets across the country, and we are under what is considered an average as far as healthcare growth. So, I think at this point we would say, yes, they are saving us money, but that's not the only reason that we contract with managed care organizations. We also contract with them because they can provide value-added services. They come with a case management system that should be able to look at the whole person delivery and case management. They should be able to just coordinate a little bit better because everything's under one roof, so to say. They also, through a managed care program, we can pay for service payable under a fee-for-service program. So some examples to that are, if we didn't have managed care, we wouldn't be able to pay for inpatient substance use treatment. We wouldn't be able to pay for ad hoc or as needed respite outside of the waivers. We wouldn't be able to pay for some types of peer support. So there are definitely benefits to using a managed care platform. And I just want to remind everyone too that prior to 2016, we did have managed care, and we had behavioral health services ran under the Iowa plan, which was managed years by Magellan, and then we had Meridian doing some HMO work. So, you know, that there are pretty big benefits to using the managed care vehicle as a way to deliver services, and what kind of flexibilities that allows us through the program that ultimately is approved by our federal partners. So we'll do some work on laying that out in a more clear way so that you can have that in front of you. It's a little bit easier to understand. And then if we continue to have questions, I'm happy to go through those. All right. Last year, there was discussion about re-credentialing all of the mid-level providers to be rendering providers and not just referring. Any updates on this? Julie, I'm not familiar with this conversation. Is this a take back?
I think this is a take back. This is not ringing a bell for me either.
Okay. All right. Judy is with an orthodontic office, currently using Ability PCAs to submit claims other than to Delta Dental of Iowa. It is very hard to navigate and understand how to enter primary insurance information. I have been trying on 3 claims and have submitted 8 times and get a cyclical response. EDIS says Medicaid issue. Your team says EDIS issue, and I go back to the ACE guide to try to figure out how to enter claim, and have tried about every possible way. Judy, please send that to provider services. We want to get you paid, so we'll connect you with someone that can help you out, okay? All right, I've been unable to get clarification from both the MCOs and the state as to who we contact to actually negotiate the MCO rates as stated in our contract versus the MCO simply using the cost reports to adjust rates down, but not always adjust when costs go up, or at least not the full amount. All right. Julie, if you don't mind sending me an email directly, you should see my email in the chat box. I'd be happy to talk more. Marissa, thank you. You're a lifesaver for putting in the provider services contact information. Does IME have an electronic provider application in the works, such as a website we can log into and start and track our credentialing process? Along with that, we receive 3-page letters for each approved provider for each location. The volume of letters we receive per new physician is quite large when they participate at 45 locations. Is there a way to streamline the notification process? Penny, thank you for providing this feedback. When we think about the different ways in which we need to modernize some of our processes. It's not just thinking about modernizing it from the perspective of how, you know, Medicaid workers work and the impact to them. It's very important that anything that we do impacts our providers and our members in a positive way too. So I really appreciate the suggestion. I think it is something that we can all appreciate and should be something that we can move forward with as we're thinking about those modernization activities. Is there a certain amount of time you would like us to try to work with the MCOs on issues? I have a few claims issues and I've been working with them on for 8 months to a year with no resolution. Are we permitted to reach out after 3 or 4 months? Yes, please. All right, is there a way to do maybe group town hall meetings? For example, dental, medical, psychological, home care, et cetera. I think we could key on issues for each area a little better if the town halls would be specialized. Yeah, I think that we can do that. I don't know what that looked like because I think that the goal is for these to kind of share some information back and forth. I certainly want all of you to hear updates from me and the Medicaid team on what we're working on, and you know, doing that in multiple groups can get a little bit rote, and we all need to be kind of aware and cognizant of resource limitations. But that said, Judy, I think that there are ways that we could probably establish work groups on some of these provide and group by provider type or service type, so that we can, like you said, key in on some issues that are really more targeted towards that provider or service. So good idea. We'll work on building out a plan for that and get back to the group by next month's town hall. Why does it take so long for Iowa MCD to get the addendums out and get them to the MCOs? Iowa Medicaid. I'm guessing this is rate related for the fee schedules. Kelly, if you have specific areas or wait times that you want us to look into, I would be happy to. Will these questions that people are asking and having to submit to you by email be answered in the next town hall? Kevin, do you think that we can be able to share an FAQ or some type of Q&A to the participants or that come on the next town hall?
Yes,
Or,
yeah, we will get a transcript of the entire chat so we can answer the questions individually, and we could post them on the website, or we can share with participants. So yes, we can definitely do that.
thanks, Kevin. All right, wasn't the MCO supposed to reach out to patients when they are frequent flyers in an emergency department? We are nonprofit and have several that will come here for convenience or because the private clinics will no longer see them. Cannot advise the patient that they should be seeing a PCP and not come to the ED. Jolene, are you able to share what nonprofit you're with or what area of the state? Maybe you can share that in the chat or send me an email directly. You know, we do want to make sure that we're keeping an eye on that. I think This may, I mean, it's been a long-standing challenge with healthcare in general, but I would say Medicaid recipients in particular, because we have a lot of social determinants at play that don't necessarily allow for or create a good pathway for healthcare engagement. So there is a pattern of using the emergency department as their normal healthcare provider, and that's definitely something that we want to be able to educate people on and do what we can to change that level of healthcare engagement so that we get them connected to a primary care physician rather than going into the emergency department. Times are even more challenging right now because of the pandemic that we're in, but that doesn't mean we can't work on it. We have a lot of work to do, and I'd be happy to connect with you and talk about a path forward. All right, from Nettleton Dental Group, our office sent in credentialing paperwork for our office and dentists to become providers to MCNA at the end of May and have not been notified that everything is processed and ready for us to submit claims. Sounds like it's taken a long time. Julie, do you think that one can go to provider services so you and Heather can follow up?
Yes, definitely.
All right. Okay, tried to get, we got Judy. Okay, tried to get that referred to EDISS and actually couldn't claim, so I can't repay you. Judy, if you don't mind just connecting with Sean, we'll figure it out. Just want to verify that these emails you are giving are secure. So encryption and that should secure them. We do a lot of security and privacy platforms that surround our own systems here within DHS Medicaid. Julie, I think that if they put confidential in the subject line, does that help at all?
I would have to double check on that. Or Kevin, do you know?
I don't know off the top of my head.
If you just send us an email, no PHI, we'll figure out a communication mechanism in the of us where it is encrypted, and if PHI is needed to be shared, then it will be safely transmitted. But appreciate the due diligence and checking. We understand urgent, emergent OB services are to be paid by the MCO regardless of participation. We are not contracted with AmeriGroup. When a pregnancy patient presents they are sent to labor and delivery to be evaluated. Then and AmeriGroup will not pay unless we completed prior authorization the same day patient presents to the hospital. D, I think, why don't you send that one in to provider services as well, and we'll check. I'll look into it on my end and we'll get back to you.
Liz, maybe we take like 3 more questions because we do have the member town hall coming up as well. And then, like I said, we do get a transcript of every question in the chat, and we can be sure and follow up individually if it wasn't answered today.
Okay. Sounds good. All right. we have a question. Do you really believe that case managers can advocate fully on behalf of their client and all clients' needs when they, the case managers, receive paychecks from the very source of these services, from the very pay source of these services? Any conflicts of interest? Julie, I think that this point is definitely one that is heard. We have done a lot of work to ensure that there are firewalls in place with the managed care organizations. However, I do see the concern from your end that there is an appearance of conflict. I do want to just kind of go back to the days of when we had all of the LTSS services operating through our fee-for-service program. The same types or appearance of conflicts existed then too. You know, if you think about targeted case management, and they both are paid for and employed by the Department of Human Services. I mean, that this shared employment status, things are pretty close there as well. But the firewalls that were put in place in terms of reporting structure and how things were operationalized help to preserve any type of risk or mitigate the risk for a conflict of interest. Similarly, we had providers that were both providing case management and providing the service. You know, I think that today we just have, and the way that the market works is that there will always be an appearance of conflict interest. And we just have to do all that we can to make sure that there are the appropriate reporting channels so that we can mitigate that conflict, and then really keep an eye on how service planning is developed and authorized and delivered. If you have specific concerns where you're seeing this conflict of interest come to play, please let me know. Last one. What oversight does Iowa Medicaid have over the MCO groups? And is the fee schedule for DME medical supplies carried over to the MCOs as part of that oversight? So we do have pretty robust contracts with the managed care organizations. We are very focused on ensuring that they are operating within the constructs of the contract, because ultimately we want companies to be delivering services in the way that the state policy is set up. Now, where we do get a little bit wonky is on some of those fee schedules, and there might not be an apples to apples on every single fee schedule. It kind of depends on how it's laid out in the managed care contract that we have. We do have some rates where we have alignment, but if we are to have, if we are directing the payment by the MCOs in any way to providers, we then have to set up some additional quality frameworks where we're also measuring quality outcomes for all of the providers. And so it's kind of complicated with federal regulations, but if you're having a specific issue with a fee schedule or getting paid at a certain rate for here and there, just please let us know. We're happy to follow up on that as well. Okay, you guys had a lot of great questions. I think that these are all really helpful. Like I said, we will definitely be transcribing all the questions that were asked. We'll pull all of the questions from the chat that we were not able to get to, and we will have a mechanism to get all of those responses back to you. For the individuals that recommended that we break out into different sessions to work on some provider-specific issues, I think that that's a fantastic idea. We'll work on getting that set up so that this can be more of a space to talk about things that are in flight, things that we want to work on, kind of the bigger strategic wish list items for the Medicaid program and how we can really work together to make this the best program possible, and maybe even the best in the country. So I really do sincerely thank you for all of your participation this afternoon. All of your feedback and comments are appreciated. They were thoughtful. I know I can see a lot of billing questions coming through, so those are definitely things we want to follow up on. And if there's a better way to do things, we want to get those ideas generating so that we can start tackling that. Have a great night. Send us ideas, send us questions, and take care.